Welcome to another episode of Health Matters with PA extraordinaire Lynn Szabo.
A new certification, I guess.
It is a new certification. What are we going to talk about today, Lynn?
Well, I'm giving you the straight poop. Okay.
Okay.
March is Colorectal Cancer Awareness Month, and so I thought we could elevate our awareness about it.
Oh, good topic.
Important because it's the third leading cause of cancer death in the United States. And kind of interesting, while the number of people over the age of 50 who develop colon cancer is decreasing, the number of patients under the age of 50 who develop colon cancer is increasing. And that's kind of going down into the late 20s now.
Wow.
Yeah.
I thought it was anecdotal, to be honest with you, but I have more people I know under the age of 50 in their 40s, 30s and 40s are saying that they have.
They're saying there's something
Cancer.
about kids who are born after like the mid 60s and how they were raised that seems to be triggering this.
Right. And I get this generation that sits all day and then plays on computers and goes to work on computers and there's not that movement. And then our diets have completely changed.
Yeah, maybe. It could be a lot of other things too. Science will tell. But the important thing to remember about colorectal cancer is that it's preventable, it's treatable, and it's survivable.
Nice.
Which is kind of good news.
Really?
Yeah. But survival is based on at least partially managing risk factors.
Okay.
And so there's always two kinds of risk factors. So there's the ones you can change and the ones that you're kind of stuck with. Okay, so the ones that you can't change relevant to colorectal cancer are increasing age, family history, especially there's certain families where it seems to be genetically associated.
Oh.
Happens more often in males than females, and it happens more often to people who have type 2 diabetes or inflammatory bowel disease.
Is that because of a lifestyle kind of a thing, or?
No, lifestyle will be something you could change. So the things that you can change are like an inactive lifestyle, like what you said, smoking, diet, and probably alcohol use.
Okay, so we shouldn't drink. Is this like any alcohol, or is this like excessive alcohol?
Moderate to excessive. So you should be drinking just a little alcohol.
So what is this? I guess I don't know the word to use. Safe might not be it. What is the definition of little to moderate alcohol consumption?
I think I drink once in a while. And what I mean by once in a while is probably different for men than women. Men, it's probably no more than, like a bottle of beer a week. And for women, it's probably half that.
Okay, so 12 ounces of low alcohol content drink a week, or 6 ounces for females.
Right.
One day we're going to have to talk about why that's different.
Yeah, there's a lot of reasons. But so most people think they don't drink very much, and then I'll say, well, how much do you drink? And then they tell me about 4 beers a day. That's a lot.
Wow.
And then we're told
that's a lot of calories, let alone the alcohol.
Totally. We're told as health, that's a lot of money.
Yeah.
Too.
Oh, yeah.
We're told as healthcare providers to double that in our mind. I don't know if that's fair or not, but I think
probably not.
People underestimate how much they drink. So, but why does colorectal cancer happen? And this is kind of interesting for cancers in general. So like esophageal cancer would be in this category, and like cervical cancer. So cancer often happens in cells that reproduce rapidly. So there's a high turnover of cells, like in the lining of the intestine. Remember, the intestine is part of the immune system, and that cells are being sloughed off all the time, and new ones are coming to the forefront to do the intestine-like job. And when you have that kind of turnover, every once in a while you get like a wonky one that's not made quite correctly, either for genetic reasons or environmental reasons.
So it's kind of like the copier skipped.
Right.
Okay,
right.
I gotcha.
And at that point, we call it atypical or atypia.
What's the difference between those two things?
They're the same thing. One is a medical person talking to a medical person, and one is a medical person talking to a patient. But then without intervention, they go rogue. So there's cells in the body in general whose job is to go around and pick out those kind of atypical ones and make sure they have a nuclear option, like they go away. But that system lets a couple through sometimes, and the cells that are reproducing rapidly and they're already a little abnormal, they start to go rogue, and then you develop what is a cancer. Okay.
And that happens in cells that you said that multiply quicker than rapidly. Okay.
Rapidly, yeah. And so, the other turnover might be like white cells in the body. White blood cells.
Okay.
There's a high turnover there, so there's an option or possibility that a mistake in production could happen, and then there's cells that are supposed to guard against that, but sometimes they let a few through, and then you start to have problems.
Okay.
Yeah.
So that's like, again, to reference back to the copy machine, that's like a hiccup in the copy machine and then a clog, so the cells are getting through when they shouldn't.
Right.
Okay. Like a copy jam and okay. I gotcha.
Yeah. So that means what that tells me is that when you're only stuck in atypical cells, then you have a possibility of intervention. So that means that sometimes you can take care of the problem when it's little and just a little bit wonky. And then sometimes, the problem doesn't get taken care of until it's big and catastrophic.
So that's like getting a colonoscopy and finding a polyp and taking it out versus being super sick, going to get a colonoscopy and saying, now you have cancer and we have to do surgery.
Right. Now there's a big mass.
Okay.
And so preventative stuff is really important in colon cancer. And I think that's the reason that the rates are going down in people over 50. So what symptoms should people be looking for? Well, a classic one is blood in the stool. And I know when I'm doing acute care that this is a frequent complaint. And it's easy for both the patient and the provider to blow it off.
Blood in the stool is easy to blow off? I thought that was like one of those things that was like, hey, this is an issue, you need to be seen.
Right. And then when you're in the exam room and there's a patient who's nervous about it, what they want to hear is, oh, it's probably just hemorrhoids. And you have 7.5 minutes and you already went over, but you already used up that time talking about their athlete's foot. Then it becomes easy to say, oh, I bet you probably have a fissure, which is a little tear in the anus, or you have hemorrhoids, which are varicose veins.
So that doesn't get checked, it just gets told.
It doesn't get checked. So number one, lead with that. That's your problem. And number two, keep saying, and so what are we going to do next about this? What are we going to do next? Other things you should look for is a change in bowel habits like diarrhea or constipation. But really, the most important one, I think, is a change in the caliber of the stool. So stools that are really long and skinny, and when you feel like you're pooping all the time but not really emptying your colon or your rectum, that's something that needs attention.
Okay.
Then there's a bunch of nonspecific ones like abdominal pain, unexplained weight loss, and fatigue. So this is the way I usually see it. There's an older man, maybe he's a smoker, who's all of a sudden anemic. So I saw this patient recently, and he was not anemic in last March, but he became anemic around July. So that first of all, that doesn't happen to men. There's no good reason why he would all of a sudden become anemic unless he sprung a slow leak.
Oh.
And then his weight was starting to go down. And then he starts talking to me about rectal bleeding, but he's been told by his provider that it's hemorrhoids. Although nobody's done an exam.
Oh my gosh.
Because really, as a provider, we don't really want to look at people's butts. We really
and as a patient, we don't want to drop our pants and show you our ass.
Yeah,
butts.
Although some people will if they're anxious enough. But and I don't know. Anyway, and then I ask about, have you had the routine colorectal screening? And they have no idea what that is. So that's part of the reason for this discussion today,
Okay.
is that we're going to be talking about that. And then I say, do you have a family history of colon cancer? And, oftentimes that hasn't been noted anywhere in the chart. And, that can focus on it. We look for patterns. The BRCA gene in breast cancer can express itself in men as colon cancer.
Wow.
So that gene expresses itself with multiple different types of cancers. And so you can see, if you plot out a family tree, you can see maybe all the women had breast cancer, maybe one had ovarian cancer, and all the men had colon cancer.
Oh my gosh.
Yeah. And you say, well, that's just because they worked at the mill and there were toxins.
That's exactly what we do. What toxins were you exposed to?
Right.
Like it's your fault.
Yeah. Where genetics is a prime example of risk factors that somebody can't really change.
Yeah.
Although that in the future might be different, but right now it isn't. So testing's divided into two parts, into screening or diagnostic. Okay, so I'm going to talk first about screening. So for screening only, yearly fecal occult blood testing, or what's called a FIT test. Now, I didn't really know the difference between these until this morning when I was looking it up. But a FIT test is the better test, so people should remember that one. It is more accurate because it's specifically looking for antibodies to the human blood that's in the lower intestine.
And that's the one that gets mailed to your house.
Well, there's two that are mailed to your house. One's called fecal occult blood and one's the FIT test.
Okay.
So the FIT test is looking for a more specific human blood, so not the steak you ate last night, but actually human blood, and specifically where the origin is the lower intestine. So colorectal implies the lower intestine.
Okay.
And then the occult blood test is just looking for blood. So, if you had a big old juicy piece of liver or something, you'd be picking up cow blood. So more accurate to get the FIT test. And then screening, if you don't want to take home the little card once a year, if you're not going to commit to that, because you don't want the lab person to know that you poop. First of all, they're way over it. And second of all, they just want you to be healthy. So,
yeah.
But if you don't want to do the yearly testing, then you start screening now. The recommendations are at age 45 for initial screening. We're talking about screening now, colonoscopy. So that, my day, that was 50.
Yeah.
For the initial screening one. Now it's 45, and they're hoping to get these younger people where the number has been going up. So you have to get, depending on the results, you have to get a screening in your family history. You have to get a screening colonoscopy every 3 to 5 to 10 years, depending on the findings.
Yeah.
Okay, so if they find a bunch of polyps or something and you have a bad family history, they're going to want your screening colonoscopy to be about every 3 years. And then if you're good and there's no problem and your family history is not a worry, then every 10 years you can get a colonoscopy. But here's what usually happens. Initially, the person goes with the less invasive testing. Like, who wouldn't? Colonoscopies are not completely fun, It's a little embarrassing to be have the provider who was all up in your colon last week run into you in Safeway. You know?
But here's the thing: you can get it done out of town, so that doesn't happen. And two, you don't remember any of it. The worst part of getting a colonoscopy is the prep. Right. And then you have to lose a day of your life to the prep, to getting the test done. Right. And then because of the medication they give you when they do the colonoscopy. They
want to clean you out.
Right.
So they want to get all the poop out, and they give you stuff that makes you have diarrhea. So you have to spend the day before basically on the toilet.
But even the treatment for that now is not even the day before. It is the night of.
Right.
The night before. So you take it, I think they told me when I had to go and do mine, start drinking this at 6.
Uh-huh.
Don't eat anything after 12. Take this at 6.
Right.
And then you're pooping the whole time. So you don't want to be eating. And then they tried to schedule them all before 12 o'clock so that you are done. And you have to have somebody pick you up and to drive. So other than it's a day of your life that you're missing from work and the whole thing,
Right.
the test itself is not bad. Again, it's not like you're conscious while they're doing any of that.
Well, you are conscious. You're given Versed.
Well, yes, but let me rephrase. I wouldn't look at that as being conscious if you're just compliant and you have no memory of what took place.
Right.
Yeah. So you're essentially you don't feel it, you don't know, you don't have a memory of it or any of the other things.
Yeah.
So the test itself is not the problem; it's the prep.
Right.
In my mind, having had multiple of them because of my family history and my own personal medical history. But yeah, it's
I
not the
found
end
it
of the
kind of
world.
interesting with Versed because I remember looking at the screen and going, I'm going to show them, I'm going to remember every curve, in my colon. And then all of a sudden we were in the recovery room. So yeah, Versed's a weird thing.
Right. I remember getting up and then saying something and then looking over, and I have no idea who it was that I said this to. And I was just like, oh my God, what have you made me do? I thought I was asleep.
Right. Exactly.
Yeah,
It is very trippy. And
is.
Demerol, I think, was the pain medicine that they gave at the time, last time I got one. But I imagine it's different now. So usually what happens is the person goes with the less invasive one, and they have good intentions to not only receive the little kit that you take home, but also have the provider put the order in and then take it to the lab in a timely manner and not just chuck it under the back seat of the car. You know what I'm saying?
Yeah. And then people find them all over the place in the backseat of the car, in a file cabinet. And
Right. And so you have these good intentions, and life just doesn't work that way. But if you're going to go for screening with the yearly fecal occult blood or the FIT test, then you really got to make a point of doing it.
Yeah.
Yeah. Pursuing it to get the kit and the order, and then obtaining it, and then taking it back to the lab so that they can do the testing.
Yeah.
So, and if you don't, then you're not screening yourself, and you're leaving yourself open for worsening disease.
Yeah.
If you have it.
And I'm one of those people that would rather go and get the colonoscopy than to play with my poop and put it in a package and then mail it back.
Right.
Yeah.
So for diagnosis, the colonoscopy is the gold standard, especially with biopsy, if they need to biopsy something.
Okay, there we go. Gold standard.
Yeah, and screening stops at age 75, which I think is, in my opinion, that should be a shared decision.
Yeah.
You know, what if somebody has a lot of colon cancer in their family and they can't, that's like their own personal horrible thing that would happen to them, and the thing they're most afraid of happening in their, health life.
It's almost as though we have dismissed our elders. Is like, you're old now, so you've lived to 75, so if you die tomorrow, it's okay. You've had a long enough life. That's sufficient.
Exactly.
It's the weirdest thing.
You have been very diligent about bringing in your FIT test every year. You've been on it. Yeah, but you're old now, and
you've had a long enough life. You're good done. Don't cost us any more money.
Yeah.
It's the strangest, and we do that in so many different areas of our society, and yet we look around and we have people in their late 80s and late 90s that are running around and still bowling in their bowling league and driving up to the store and taking great-great-grandchildren to school.
Healthy and vibrant, and are good operative risks if they need to have an operation to address something.
Yeah.
So I think that's kind of not fair. But
I
anyway.
agree. Maybe that's another topic.
Yeah. Of note, thanks to the Affordable Care Act, screening is still free for the patient. So if you're going in there and you're, have no reason to suspect something because you don't have the family history and you're not symptomatic, then the whole procedure is free for you unless they find something wrong.
Yay.
Yeah, so thanks, Obama.
Gotta love the Affordable Care Act,
Yeah.
otherwise known as Obamacare. And yes,
Right.
that's the same thing.
Right. So that was something that we threw away or we haven't quite thrown it away, but we're trying.
We've dismantled it. It is no longer the same.
Yeah. So after diagnosis, most treatment is surgical. The chemotherapy.
Wait. Most treatment or mistreatment?
Most treatment.
Gotcha.
But chemotherapy and immunotherapy and maybe for further surgery are important. Immunotherapy is super exciting. So if they know what's wrong on the genetic level, if they know what caused that cell to go from being normal to wonky, they can address that.
So so you said that most treatment is surgical. So why would you have surgery versus chemotherapy? Because when you think cancer, you think you have to have chemotherapy or radiation. So why is colon cancer be able to treat with surgery?
If you treat it surgically because it hasn't moved to the lymph nodes, if it's only in the colon, and you take the colon out, or at least the part that's damaged, that's diseased, then if the lymph nodes are good and the PET scans are good and everything else looks positive, and that shared decision is made between the physician and the patient, then that might be as far as it goes.
Wow. So just take out the little...
Yeah, there's no metastatic disease. So that means there's no disease outside of just the lesion in the colon.
Nice.
Yeah. So catching things early is super key.
Yeah.
Because it doesn't have to be, you have the poop bag and are all of a sudden all debilitated and made sick by radiation and chemotherapy.
Talking about a colostomy bag.
Yeah.
Okay.
Yeah. People call it a poop bag.
Gotcha.
Yeah. So what should somebody do to never get to this point? So prevention,
Don't have a colon.
Yeah, you need a colon. You really need a colon.
Everybody needs an asshole.
Yeah. So prevention. So like we talk about a lot, a diet and exercise, super important. As far as diet, make it a healthy plant-based diet.
That's no fun.
Yeah, I know. Avoid refined sugar. Increase consumption of fish if you want to go for flesh. If you're a flesh eater, then fish is the one to go for.
It's not the same as a nice rare steak.
I get it. Decrease red and processed meats. So my Achilles on this one is salami, actually.
Oh, that's not processed.
Yeah, it is. It can have different levels of processing, but anyway. So decrease the amount of alcohol you take, and it's looking like some vitamins like B2 and B9 is folate, are good to increase in your diet. And so before you run down to your drugstore of choice and buy it off the shelf, really the difference applies specifically to diet sources, not pills, not supplementation.
Oh.
So look for sources like dark green leafy vegetables and beef liver. I wrote ugh because who wants to eat beef liver?
Yeah, no thank you.
Yeah. Consider increasing your vitamin D and calcium. But
Chocolate
again,
milk?
Yeah.
No, does chocolate milk count? It's got vitamin D and calcium.
It's got caffeine in it, which would lower your calcium absorption.
Chocolate milk?
Yeah, I know. Who knew all these
But
years?
not if it's hot chocolate, right?
I would go for the sunlight and go for calcium-rich foods. And fortified milk is a good one, but chocolate milk not as good. So, and then there was some talk about daily low-dose aspirin or non-steroidal anti-inflammatory drugs, but this has not really been borne out as conclusive. And so if you have another reason to take it, like for example, I take low-dose aspirin every day because I'm diabetic with higher cholesterol, then that happens to be icing on the cake, but don't start taking it without advice from your physician or your provider.
Okay. All right, that's good advice.
Yeah, so survival rate at 5 years for colon cancer is 65.4%. So you have
Wow.
a greater than 50-50 chance. It's better in white people and worse in Black people and natives.
Is that because of inequities in healthcare?
I think there's probably both inequity and a genetic thing. I wonder if that's maybe related to the vitamin D. People with low vitamin Ds tend to get cancer more often. And I've seen some really low vitamin Ds here.
Oh, yeah.
Yeah, we do them routinely, yearly on otherwise healthy patients at UHS. And I've seen, normal is 30 to, 60. And I've seen like some 5s, 7s.
Yeah.
So it's a big deal.
Mine's habitually low. That even when I take vitamin D, the 50,000 units,
Sunlight's probably what you're missing.
Yeah.
And here we live in a temperate rainforest.
Right. And I garden and I hike and I go to the beach. So
yeah. Well, basically, you kind of have to garden with more skin exposed, which makes the dermatologist kind of lose their mind. Yeah. So, but that doesn't mean you should go out with the intent to get sunburned.
Gotcha.
So that's the story. That's all the poop on colorectal cancer. And I think it's important to talk about, although poop isn't really talked about very much in the exam room. Although occasionally I'll get pictures of odd bowel movements and stuff.
Oh, that can't be fun.
Yeah, it depends how clinically engaged I am. But there's a lot of baby diapers with weird stuff in it. But it doesn't matter what color it is. There's always people trying to demonstrate a certain color. It's either got blood in it or it doesn't.
Gotcha.
It's either got worms in it or it doesn't.
Ew.
Yeah. So,
Gross.
What I'm asking listeners to consider is, are you up to date with your preventative health care? We used to have most of the women in the country trained to get their pap smears once a year. Are you paying attention to testing your stool once a year? And are you paying attention to which tests they use? Because they offer both. And actually, I think the FIT test is superior.
Okay.
If you want something more sensitive and specific. And, are you getting the colonoscopy when it's ordered, or are you just getting the referral and then forgetting about it?
Yeah.
Super important. This is so curable, and so it's also important to understand because maybe your kids are going to be affected by the genetics
or be affected if you get cancer and die because you waited until it metastasized and went into your lungs and your lymph nodes and everything else.
A very scary presentation in the exam room when you see, especially a man who's got a little bit of anemia and a little bit of weight loss, and people are still talking about hemorrhoids.
Yeah.
You can have hemorrhoids and you can have colon cancer at the same time.
Right.
So poor hemorrhoids, they get blamed for everything, but nobody ever actually really tries to look or to solve that problem. Okay, because it's poop, we don't want to think about it, and that's unfortunate because we could have done something to keep somebody healthy.
Yeah.
For longer. So.
All right. Well, so what are we going to talk about next week?
I was thinking about talking about. It's an over-the-counter. It's not a medication, but it's a nutritional supplement that people take for all kinds of things like pain. And I think and correct me if I'm not pronouncing it right, but I think it's called Crackum.
I have no idea.
Do you know? Okay.
Never heard of this.
Yeah. I know a lot of people that admit to taking it, but I'm not sure it's a great idea.
All right.
Yeah.
Well, that'll be interesting.
So we'll talk about that. And then whatever comes up in the course of the week that's of interest to me.
I love that. Everything interests you. You're curious about everything, Lynn.
I know, I am. Having a good time at acute care and also teen clinic. We've seen a lot of patients lately. We're getting over the flu, which is good. And, we'll see what else April brings us.
Great. All right. Well, thank you so very much for reminding us to get our colonoscopies and to do the FIT test.
Yep.
The at-home test. And if you are the makers of the FIT test and you would like to sponsor Health Matters, go ahead and give me a call or email me. And if you're a hemorrhoid, and same thing, if you'd like to sponsor the show and not be blamed for everything, do some underwriting, go ahead and shoot us an email.
It's not your fault.
It's not your fault.
Yeah.
All right. Thanks, Lynn. I'll see you next week.
All righty. Bye-bye.